Good morning. My name is Dr. Robert Tanenberg. I'm an endocrinologist from East Carolina University. I'm a professor of medicine there. I also am the medical director of the Diabetes and Obesity Institute at East Carolina University. I'm here today at the Cardiometabolic Health Conference to talk about type 2 diabetes. As you know, type 2 diabetes is a rampant disease. It's becoming increasingly prevalent throughout the country, almost 10%. Drugs for type 2 diabetes have increased dramatically. We used to one time only had sulfonylurea and insulin, and now we have 12 different classes of drugs. We have 45 separate drugs plus combination drugs. And we have some new insulins that are coming out that are very exciting as well. So one of the things that happens in primary care is physicians try the patients on metformin and maybe sulfonylurea, and eventually they fail. And then they put them on a basal insulin, such as glargine or Detmer insulin. And that may work for a while, but eventually what happens is the patient's blood sugars go higher, their A1C comes up, and the question is, what do you do next? So first of all, you have to make sure the patient's on the proper nutrition, maybe exercising, and make sure you've utilized the oral agents that are available, such as DPP-4s or metformin. And that's still not working. You want to take a look at what the fasting blood sugar is. If the fasting blood sugar is under 120, but the A1C is high, we know that the problem is postprandial. Studies show when your A1C is 10% or more, 70% of that A1C is fasting. When it's 8.5, it's 50-50, but as the A1C gets down to about 7.5, 7.3, about 75% of that glycemia is due to postprandial. So there are really two options that I find works best. One is to use a Glp-1 agonist. So if you use a Glp-1 agonist, such as exenatide or liraglutide, together with basal insulin metformin, that's a very, very potent combination. And many patients will bring their A1C under 7%, and many of them will lose weight as well. And there's a lot of durability to that combination. If patients can't tolerate those drugs because they can cause nausea or cannot afford them because they're expensive, another option would be, rather than going to a 4-shot program, doing the basal plus 1. Since most Americans have their largest meal at supper, we did a study we published showing that if you gave a short-acting insulin with the supper meal together with the basal, at least 40 to 50% more of those people could get their A1C below 7. And when you gave 3 shots a day, it was only slightly better. So that's another way that patients do well, is to try to take the basal plus 1. So then you have to decide in terms of incretin or basal plus 1, what's better. And what you might want to do is, what is the patient's weight? If their weight is a more pressing issue, I think then if they can tolerate the GLP-1, that's another issue. So now we have the question of whether the patient needs to be on more than 2 injections. So something that just came out this year is inhaled insulin. There was a former inhaled insulin that came out in 2006. It was taken off the market not because of safety issues, but because it wasn't selling properly. The device was very large, hard to use, and it just didn't take off, and the company withdrew it. So a new company now has come up with inhaled insulin, which is a very, very small device. It looks really about the size of a little whistle, and you just load in this 4 units or 8 units into there, and you just take an inhale like that, and then you dispose of that part, and you dispose of the little inhaler every 2 weeks. So if patients are reluctant to take injections at meal times, this might be a new alternative for them to take along with the basal, because you really still need a basal insulin in most cases of type 2 diabetes to go along with the pre-meal insulin. So in summary, we have a lot of options now for patients with type 2 diabetes, which do better jobs of keeping their A1C in control, better jobs of keeping the weight down, and hopefully less hypoglycemia. And I didn't mention, but the inhaled insulin seemed to have less hypoglycemia than the standard insulin, such as lispro-aspart. So all these different options are to try to get what we call the trifecta for diabetes. You want the A1C less than 7, you don't want any weight gain, hopefully weight loss, and you don't want any hypoglycemia. And with those goals, I think we can achieve good control in most patients who are compliant and who have been educated. Thank you very much.